कृष्णपिङ्गाक्षं गजवक्त्रं चतुर्धकं लम्बोदरं पञ्चमञ्च षष्ठं द्विकटमेव च सप्तमं विघ्नराजेन्द्रं धूम्रवर्णं तथाष्टमं नवमं बालचन्द्रं च दशवन्तु विनायकम् एकादशं श्रीगणपतिं द्वादशन्तु गजाननं द्वादशैतानि नामानि त्रिसन्ध्ययस्फटे नरः न च विघ्नभयं तस्य सर्वसिद्धिकरं प्रभो. Thank you.
Thanks a lot, Ms. Shri Priya, for the soulful rendition. I request our beloved CEO, Organizing Secretary of 5th OFISACON, Dr. Suman Shri, to welcome the august audience. Over to you, madam.
Hari Om. Good evening to all of you. It gives me immense pleasure to extend a very warm welcome to the 5th OFISACON 2019, the Ophthalmic Forum of Indian Society of Anaesthesiology, which is also affiliated to the Indian Society of Anaesthetists. Ophthalmic anesthesia is a relatively new and budding subspecialty for anesthesiologists. The special challenges of the extremes of age, that is, pediatric and the geriatric group of patients, has catalyzed the need for specialization in ophthalmic anesthesia. The expertise and safe practices of the ophthalmologists and the anesthesiologists are crucial for best clinical outcomes. Nethradhama has successfully completed 25 years in July 2019. We strongly believe that only quality can sustain growth consistently. The theme of this year's conference is Quality and Safety in Ophthalmic Practice. Nethradhama has made a name in the quality circles. We've been conferred the D.L. Shah Gold Champion Award and the D.L. Shah Silver Award for our Kaizen project in 2019 by the Quality Council of India and the D.L. Shah Trust. I am deeply honored and privileged to welcome on stage Professor Chandra M. Kumar. He is a professor of practice, Newcastle University, UK, and a senior consultant in anesthesia, Kutek Puat Hospital, Singapore. He has received the FFARCS from the College of Anaesthetists, Dublin, and FRCA from the Royal College of Anaesthetists, London. He founded the British Ophthalmic Anaesthesia Society in 1999 and the World Congress of Ophthalmic Anaesthesia 2004. Welcome to you, sir. Please. So please, yeah, please. It's my pleasure to invite on stage our beloved Chairman and Managing Director, Dr. Sri Ganesh, who is a pioneer and a global trainer in the field of phacoemulsification and refractive surgery. He has been recently conferred the honorary FRCS from the Royal College of Surgeons, Glasgow. I deem it a privilege to welcome Dr. Jayachandran VV, who is the Secretary of OFISACON and the Consultant Anesthesiologist at Shankara Nethralaya, Chennai. I extend a very warm welcome to Dr. Divakar, who is the president of the Bangalore Ophthalmic Society and our KMC observer. Welcome, sir. I extend a very hearty welcome to our guests of honor, our beloved parents, Shri S.N. Raja Rao, Shrimati Lalita Rao. Please come on stage. I deem it a privilege to welcome my mother, Dr. Srimati Vanitha Ramaswamy. I take this opportunity to also thank Karnataka Ophthalmic Society, the Bangalore Ophthalmic Society, and the Indian Society of Anaesthesia Bangalore branch for their support and for inspiring us. I take this opportunity also to welcome our international faculty, Dr. Alfred Chua, Associate Professor Edwin Seat, Associate Professor Oya Yelchin Kok, Dr. Tom Eck, Dr. Paul Williams, Dr. Frederick Leach, and I take this opportunity in expressing my gratitude for accepting my humble invitation for this conference. It's indeed an honor to welcome all the national faculty, Professor Renu Sinha, Dr. Rasesh Diwan, Dr. Jagdish V, Dr. Raja Narasimha Rao, Dr. S.C. Parak, Dr. Multan M. Sharma, Dr. Murli Chakravarti, Dr. Pushpa Susan, Dr. Renuka Sridevi, Dr. Kannan, Dr. Murli Srinivasan, Dr. Pushpa Lengade, Dr. Pragnya Sriram, Mr. Shripad Jogarao, who are all stalwarts in their respective fields. I also welcome our host faculty from Nethradhama, Dr. Savita Arun, Dr. Namita Sianagol, Dr. Anup, Dr. Sudha, Dr. Chinmay Vyas for their enriching contributions. Last but not the least, I welcome all the delegates and attendees, the staff and doctors of Nethradhama for making this dream a reality today. I also welcome all our sponsors who have supported us wholeheartedly for this event, without which such a grand event could not have been organized. And I wish you all a very enjoyable and educative interactive conference, and happy Onam.
Thank you, madam. Light or Agni is a beautiful imagination that Indians gave to the world. It symbolizes auspiciousness, prosperity, abundance, and harmony. Let us begin this inaugural ceremony with harmony. I request the dignitaries on stage to light the lamp and formally inaugurate the conference.
शुभं करोति कल्याणम् आरोग्यं धनसम्पदा शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिपरब्रह्मा दीपज्योतिर्जनार्दनः दीपो हरतु मे पापम् सन्ध्यादीपं नमोऽस्तु ते सन्ध्यादीपं नमोऽस्तु ते सन्ध्यादीपं नमोऽस्तु ते नमोऽस्तु ते नमोऽस्तु ते.
I thank the dignitaries for their blessings. I request them to take their seats. I request them to take their seat on the hall. As we step into the 25th year, it's time to look back with pride, gratification, satisfaction, and sense of fulfillment at the journey of Nethradhama Hospitals Private Limited. It started as a solo practice by Dr. Sri Ganesh, a visionary, I must say, with the blessings of his parents and support of his best half, Dr. Suman Shri. And it has grown beyond imagination. We are proud to be known for state-of-art technology, quality, research, and education. Nethradhama Hospitals Private Limited is proud to have excellent, dedicated team which have contributed to the success immensely. Montage of Nethradhama Hospitals Private Limited incredible journey of 25 years will be played. Team Nethradhama, many, many more years of this incredible journey. OFISA, Ophthalmic Forum of Indian Society of Anaesthesiologists. Dr. Jayachandran, a senior anesthesiologist and also secretary of OFISA, will present a video about the same. Over to you, sir.
So before I could talk about OFISA, I just want to thank Dr. Suman Shri and Dr. Sri Ganesh for having conducting our 5th OFISACON in a very successful and a grand manner. And really you have a spirited team behind this for this doing a conference in such a huge grand manner. And one more news which I would like to share with you, which many of the faculties would not be aware of. Just 1 month ago only, they had their elder daughter got married, ceremony done. So in spite of this busy schedule, imagine they are conducting this conference in a grand manner. I think they just require a big round of applause. Because initially I never knew that marriage ceremony was going. So I was just like that, I was contacting over phone Dr. Shuman Shri. Each and every time, she was very coolly answering me. Then later on only I came to know that the marriage ceremony was going on. Thank you, Dr. Shuman Shri. And on my behalf, I would just like to give a small gift to both Dr. Shuman Shri and Sri Ganesh. Please. Moving on to my topic, that is Ophthalmic Forum of Indian Society of Anaesthesiologists. I have few enquiries today regarding what is this, where is the website, how to register. This is the website for our Ophthalmic Forum of Indian Society of Anaesthesiologists. You can just like that go here and you can register. Membership is, as of now, it is free here. So you can just go and make yourself register online. It is free as of now. And we have issue of newsletter once in 6 months. This is our 10th issue, which we have recently got it. These are all the previous issue. You can download it and read, which contains all interesting case reports and update in ophthalmic anesthesia. Actually, OFISA was started in the year 2009, mainly with the aim of to bring both ophthalmologists and anesthesiologists in a common platform to exchange their mutual knowledge and update in the field of ophthalmic anesthesia. With this as a main aim, we started this. Now, the small video, we will see how the journey went on. Video. The video. The video. In the end of the video, you will see. waited for that. Many of them were asking. Just stop. Many of them were asking who is going to host the 6th OFISACON. Actually, when I was looking for the suitable host, suddenly I received a phone call from Dr. Pushpa. Very frantically, she called me saying Dr. Giridhar again wants to do that for the second time, the 6th OFISACON. It's so nice that an ophthalmologist recognizes that a forum, and so he immediately asked whether there are any bidders for that 6th OFISACON. But luckily there was no bidders, so I immediately agreed to it. I now call upon Dr. Pushpa to officially invite that speakers and delegates for the next OFISACON.
Thank you, Jay. This is indeed a great pleasure to be standing here before all of you, and we warmly welcome you and we invite you heartily to please join us at the 6th OFISACON in Cochin in 2021. The dates will be decided and announced later. Please do come.
Thank you. Thank you once again. Thank you.
Thanks a lot, sir, for the brief overview. Now we have an interesting keynote address by Dr. Sri Ganesh, our beloved CMD, Nethradhama Hospitals Private Limited, who is synonymous with innovation and best phaco-refractive practices. Dr. Sri Ganesh is Chairman and Managing Director, Nethradhama Hospitals Private Limited. This was the first eye hospital in India to get NABH accreditation. His main interests are cataract and refractive surgery. He is known for innovations and technology. He has numerous publications in various international peer-reviewed journals on refractive surgery and has performed over 100 live surgical demonstrations in various conferences and has presented many papers in national and international conferences. He has many awards and to his credit. He was awarded FRCS by Royal College of Surgeons, Glasgow in the year 2018. Honorary doctorate, Doctor of Science, has been conferred by Rajiv Gandhi University of Health Science for his contribution in the field of ophthalmology in the year 2014. And he was awarded Shiva Prasad Hardria Award for Best Paper in Refractive Surgery in the 73rd AIOS conference, and he is the recipient of Colonel Rangachari Award for overall Best Free Paper in Kolkata. Dr. Sri Ganesh was honored with Oscar's Gold Medal Oration Award from Graham Barrett in Australia in the year 2017. Over to you, sir.
Thank you, Dr. Savita. Good evening, dear friends, respected colleagues, my parents, my mother-in-law. I was wondering what to speak, and then I thought I would give this talk on Back to the Future, the evolution of ophthalmic anesthesia. So let's delve into the history of ophthalmic anesthesia and see how we have come back to the future. We all know Sushruta, the famous ancient surgeon who described a lot of principles from cataract surgery to plastic surgery, and plastic surgery even today he's being quoted. And he described couching first, where the cataract was depressed into the vitreous. So a mature cataract was depressed into the vitreous, and then this used to clear the visual axis, and then patients were able to see. This was in 600 BC. And he used inhalation anesthesia with herbs for performing ocular surgeries, though the details of which are not very well known. That's a wax model of Sushruta performing couching. The Egyptians also performed couching by carotid compression. So they knocked out the patient by carotid compression and then performed couching. They also had some crude methods of hitting patients on their head and then knocking them out and then doing the couching, which then there was the use of hypothermia for Dioscorides, a Greek surgeon and botanist, and Celsus, who was the author of De Ra Medicina, pointed out the cooling effects of these herbs, and the cooling effect of these herbs provided anesthesia. And then Hyoscyamus niger was first used for the inducing hypothermia and then doing the couching. Then began the search for local anesthetics. Poppy was being used, and the Chinese used to use a lot of opioids. And mandragora was used by Dioscorides for mixing with wine to give general anesthesia for couching. People even tried alcohol, but the problem with alcohol is you required it in fairly high quantities to knock out the patient, and there were a lot of other side effects. The Chinese also used acupuncture to reduce pain while doing couching. And then there was the story of cocaine, which was the drug for topical anesthesia. In 1855, Gadek extracted the alkaloid erythroxylin from coca leaves, and the drug was isolated and named cocaine by Albert Niemann. Cocaine also provided mydriasis, dilatation of the pupil, and this was first appreciated by von Anrep in 1879. So it was ideal because it caused dilatation of the pupil also and gave some amount of surface anesthesia. And so the first effective local anesthetic for ocular use, surface anesthesia, was cocaine. And there was a story that in 1884, Karl Kohler, who was a friend of Sigmund Freud was interested in cerebral stimulation effects of cocaine, and then Karl Kohler was his friend, and he gave him a small sample of cocaine in an envelope which he put in his pocket, and then the envelope had leaked, and then a few grains of cocaine were stuck on Kohler's finger when he tried to remove it, and then he licked it, and then he found that his tongue became numb. And then he had the eureka moment, and then he decided he would use it for topical anesthesia. And so he came to be known as Coca-Cola. Karl Kohler was an Austrian ophthalmologist. He experimented upon himself by applying cocaine solution to his own eye and then pricking himself with pins to see the effect, and that was the first effective local anesthetic which became quite popular for cataract surgery. Then came the regional blocks, but before that was the invention of the hypodermic needle, because without a needle you can't give a block. And in 1844, Rind of Ireland designed a metal hollow tube to deliver medications hypodermically, and this was inspired by the bee sting, which was a hollow tube. The sting was a hollow tube, so they made a hollow needle. And in 1853, Charles Gabriel invented the hypodermic syringe, and in 1855, the hollow needle was further refined by Alexander Wood to inject IV morphine for analgesia. In the same year, 1884, that Karl Kohler used cocaine, Hermann Knapp used cocaine for retrobulbar injection and performed an enucleation, but they had serious complications associated with it because of the toxicity of the cocaine, not only systemic toxicity but also local necrosis, and this halted the further development of local anesthesia techniques temporarily. And there was a search for an alternative because cocaine caused a lot of side effects like excitation, cerebral stimulation, hypertensive episodes, corneal epithelial erosion, and sometimes even corneal ulceration. And the widely dilated pupil sometimes caused an angle closure attack. And of course, there was always a chance of misuse by the handlers. And so they were looking at an alternative for cocaine. Procaine in 1899, Einhorn determined the chemical composition of cocaine and noted that other agents with similar structures also acted as anesthetic agents. And 6 years later, he reported the discovery of procaine, which is an effective anesthetic agent that was less toxic than cocaine, but procaine had a shorter duration of action, 30 to 45 minutes. So they were looking for anesthetics which could prolong the action, because then the newer developments in cataract surgery happened and it used to take time. Of course, now we can do a cataract surgery in 2.5 to 3 minutes, but then when these techniques of extracapsular cataract surgery and IOL implantation were happening, they needed a longer duration of action, and so the other agents like tetracaine, lidocaine, mepivacaine and bupivacaine came into action. And today mainly lignocaine and bupivacaine are the drugs which are used almost in all ophthalmic procedures in blocks. Also, we use adjunts with the blocks. In 1899, Abel and Associates, they isolated and described the chemical nature of an active salt from crystals from the suprarenal gland and named it epinephrine. And the vasoconstricting effect of epinephrine not only retarded the absorption of the anesthetic, but also prolonged the anesthetic effect and did diminish the systemic absorption and toxicity also. Hyaluronidase was extracted from the testicles of rats and rabbits and also used for its spreading factor. And in 1937, Mayer and Associates noted hyaluronidase enhances the diffusion of the local anesthetic agent. And but the problem is the impurities in the testicular extract had stimulated cell proliferation and tumor growth, and so it was discouraged. But later on in 1949, a highly purified hyaluronidase that did not stimulate cell growth became available, and even now hyaluronidase is being used regularly for blocks to make it more effective. In 1885, William Halstead first introduced the idea of regional nerve root infiltration by injection of cocaine, but 2 decades later, Van Lint, an ophthalmologist, introduced his technique for facial nerve block to produce total akinesia of the orbicularis, which eliminated the patient from squeezing the eye during the intraocular surgery. And there are various facial nerve blocks like Van Lint, O'Brien, Atkins, Nadbath. I think all these have been discussed in the morning, so I will not really go through it. I think we'll just skip through this because it's already been covered, Atkins and Nadbath. And the anatomy. The first retrobulbar block was given in 1948 by Atkinson, and then he described the detailed technique and the anatomy of how to give a retrobulbar block. But still the retrobulbar block had several shortcomings of optic nerve penetration and globe perforations, which can be very serious side effects. Strauss and colleagues, Buttery and Weiss, suggested the use of a curved needle to reduce the complications. Duke and co-workers reported inadvertent globe perforation during retrobulbar and peribulbar anesthesia to be approximately 1 in 140 injections in the eye with axial lengths greater than 26 millimeters. So eventually they moved away from retrobulbar blocks, and the peribulbar blocks became more popular. It was described in 1980s by Dr. David and Mandel. After performing several ultrasound guided studies, the size of the needle for a safe extracorneal injection was decided to be about 25 millimeters, 2.5 centimeters. The subtenon block evolved, and Rizzuti first used subtenon block for performing optic nerve fenestration surgery, and Fujishima et al. Used subtenon block for strabismus surgery. And this is the details. I think again the subtenon block has been covered in detail, so I will not go through the exact technique of giving a subtenon, but there are both advantages and disadvantages of the subtenon block. Advantages is virtually painless. It gives good analgesia and akinesia, avoids complications of sharp needles because you are using a blunt needle. Low risk of serious complications, and there's no need for a facial block. Safe in patients with anticoagulants, and safe in eyes with long axial lengths, and there's minimal or no rise in IOP. But the disadvantages is there can be subconjunctival hemorrhage, chemosis, and cosmetically it may not look very good after the surgery, and you have to be careful when doing scleral buckles. Now we are back to topical anesthesia. We started with topical anesthesia. Novak and Koch reported no complications when phacoemulsification was performed using topical anesthesia, and intravenous sedation. And 90% of the patient reported no intraoperative discomfort. Duguid and colleagues assessed the pain level with the use of a visual analog scale with Smiley 0 to 10 as patients underwent phaco with topical anesthesia or peribulbar anesthesia, and they found that topical anesthesia is very comfortable. We also supplement with intracameral xylocaine, preservative-free xylocaine, to improve the efficacy of the topical anesthesia. And I think Samuel Mascott has done some work on this and brought about the first few papers on comparison. So if you look at it, we started with inhalation anesthesia way back in 600 BC with Sushruta, went on to topical hypothermia, then topical cocaine, injection cocaine, then regional nerve blocks, facial nerve blocks with lignocaine, then the retrobulbar block, subtenon's block and peribulbar block, and then back again to topical drops, so we are back to the future. We started with topical and now we are again back to topical anesthesia, and that's the complete cycle. Thank you very much for your attention.
Thank you, sir, for the insightful talk with the refreshing facts. Next, we move on to the next keynote address by accomplished and eminent anesthesiologist, Dr. Chandra M. Kumar. He is the professor and senior consultant at Kutek Hospital, Singapore. He has various international publications. He is the founder, British Ophthalmic Anaesthesia Society. He is the founder, World Congress of Ophthalmic Anaesthesia. He is the past council member, Association of Anaesthesiologists of Great Britain and Ireland. He was the recipient of Britain Top Doctor and Platinum Award holder. He is a past council member, the Royal College of Anaesthesiologists, London. Over to you, sir. He'll be delivering a keynote address on anesthesia for patients with dementia. Over to you, sir.
Thank you. That one. Thank you, Madam Chairman, for the introduction. And I would like to thank Suman Sri and Sri Ganesh and OFISA for inviting me to their prestigious place in this beautiful city. And I would also like to thank my fellow speakers from different parts of the world as well as from India. So distinguished guests, friends, families. The topic I have been given is anesthesia for patients with the dementia. As you would know, the dementia is a terrible condition, terrible. And if you got to deal with that, it's a very, very difficult issue. But people disregard that. And I'll show you what happens actually in the practice. I know some of you are non-medic, so I will try to concentrate on general terms, if possible, but somehow it's unavoidable at places. Okay. So I don't have any financial interest. I'm only interested in anesthesia for the elderly, the aged, and ophthalmology. And I would like to put my hand up in the air saying I'm not an expert in dementia. But what has happened over the years while I have been in Singapore, that I deal with 6 to 8 patients per week. Okay, that's the enormity of the problem. Okay. So these are my books which I have written on or co-authored on elderly. And this is the book I've done on anesthesia. There was another one on ophthalmic. And the last book is by Jai, myself, and Jagdish sitting in the audience. Now, we know there are some ophthalmologists here that the visual impairment may occur due to cataract and or dementia, both. And you don't know why the patient is not able to see because the patient doesn't respond to you that well. So it's a very difficult at times unless you see the patient with the microscope and do the other tests to know that. Unfortunately, when these patients come to operation, they are given general anesthesia as a choice. And I'll show you why that may be. When you look at the literature, there is very little and no research on anesthesia and cataract surgery in patients with the dementia. So now you can see my problem. I deal with 6 to 8 patients per week, and I know not much about anesthesia, what to do about that. However, recently, there have been a guideline published on dementia in general for orthopedic or other operation. Again, nothing on eyes. So, this is the first paper I found. And look at the title. It's a Challenges of the Cataract Surgeon. And this is a very interesting paper. One of the co-author, Michael Clark, I knew him for a long time. He's a neighboring hospital, and he also worked in my hospital. He published, and his colleagues, what are the challenges? They didn't say how they do it. They said these are the challenges. And I'll go a bit detail later. So as I was struggling with all these patients, I came across with my brilliant and talented head of the department, Professor Edwin Sheet. You have heard him this morning, what a brilliant lecture he gave. We looked at the problem. We said, can we have an option? Is it what the surgeon has written, the patient is labeled as dementia, goes to the ophthalmic surgeon, says general anesthesia. End of the story. So I was anesthetizing with general anesthesia with most of the patients. So this was the first paper we wrote, and still I claim probably that this is the first something to offer on anesthesia in patients with the dementia for cataract surgery. I'm not talking about others. Then we did some more work, Edwin, myself, and one of the brilliant ophthalmic surgeons, she actually comes from Bangalore, but she's one of my colleagues, a very nice lady called Dr. Lekha. I'll go into that paper that bit later. And this is the guideline was published, and I did not have the faintest idea, but the three of the authors in there, one is Ian Moppet, who is a deputy editor-in-chief of BJA, Irwin Fu, who is interested in aging anesthesia, and there's another guy called Richard Griffith. He's interested in aging, and he deals with mostly orthopedic. So I had a congratulatory email from Ian Moppet when our paper was published saying, hey, what a brilliant job you have done. And there were a lot of support from colleagues around the world saying, thank you very much for highlighting the problems. Okay. So now I'm going to briefly look at under 4 headings. Let's look at what is dementia. Now, the dementia, there are a couple of words in there which are very important because I'm going to elaborate a little bit more later on. It is a syndrome with a slowly progressive loss of cognitive function. Progressive, that is not going to come back. It's going to get worse. But it exceeds the normal cognitive age related to age. So as we get older, which I'm 71, and I'm losing a bit of memory. And I suppose many people of my age will be losing too. But this is progressive. The memory loss of aging is not progressive. So that's important. The second thing is the dementia or the memory loss is so that it is impair the cognitive function sufficient to interfere with the social or occupational functioning, i.e. the person is not able to do what he or she was going to do before. Not able to cook, not able to take a bath, or whatever. Again, we'll come back to that. So how is the dementia manifested? A headline, simple forgetfulness is not dementia. I'm looking for my keys or my pen or my letter. That's not dementia. But what dementia is this. The loss of sense of time and place. Keep getting lost. You go out and don't come home. Come home after 2 hours, 3 hours. Had the dinner or lunch, forgotten about it. No idea. Forgets routine task. And also, these people, as they get progressively, they become depressed, they become irritable. There is no communication in the later stages of dementia. And of course, these people are not able to take decisions. And there are different types of dementia. The whole list. I'm not going to go into the detail, but Alzheimer's is the commonest, 60 to 80%. So whatever we know about anesthesia surgery, we know about from the Alzheimer's disease. So we will apply the same principle if we are dealing with the other type of dementia. So from here, I will be talking on Alzheimer's. Look at the world population. It's going up. So currently, the world population is about 7.5 billion. And now by 2050, it's going to be 9 billion. And look at the dementia, what's happening. This is also going up. Poorer the country, higher the rate. And the bottom one is the developed country, where it is increasing, but not that rapidly. So what's happening in my old country and your country, India? The population of India is going to get more than the China. China is red. So Indian population is going, and you hear Mr. Modi talking about मेरे देशवासियों 125 करोड़ जनता, and he takes pride in that one because that's something to do with the business. But our population is growing. And as the population of India growing or anywhere, what's happening to them? That was 2016. India had 4.4 million people with dementia. And by 2050, it's going to be 12 million. So you can see the enormity of the problem coming your way. So what are the implications for these people? They are living longer, and they will get more dementia. And I'm currently working for 9 years, my lovely country, Singapore now, where Singapore is the number 2 in the world where people are living longest living after Japan. So then you can imagine why I'm seeing 6 to 8%, 8 patients per week. Okay, so as the people are living longer, these patients will get more problem. They will need more surgery. And of course, they need more surgery. They will need anesthesia too. And all sectors which deals with the dementia, they are all affected. You call it, they're all got to do the planning, the money side and everything. How about the ophthalmologists? Why are they, is my time up? Sorry. What are the ophthalmology challenges? I referred to this paper before. So this was the study where they asked the ophthalmologist, what problem you think dementia can cause you? And there are a whole lot of problems. I've not cut paste all of them, but there are problems. I will summarize for you. They say the patient do not understand. They can't cooperate. They can't communicate. I do not expect my patient to have cooperation for longer. The patient might sit up during the operation. They might move. There are many other issues. So majority of surgeons, eye surgeons, say, I want general anesthesia. Well, practices do vary. So the practices vary, and the conclusion, they said, there is increased time at pre-assessment and anesthetic support may be beneficial. What they are looking for is there another way? That's where we come in. Prof. Edwin Seat and myself, we sat on this problem. Do we have another option? So we'll be exploring that. So what are anesthetist problems? The anesthetist problems are, I can't go into very much detail, but just briefly try to summarize for you to build up the scenario why anesthetists would be concerned. Now, I have established to you the patients are living longer, the incidence of dementia would be higher, so these patients are elderly, and they are getting dementia. So what are the problems with them? 20% reduction in the blood flow to the brain. Okay? And what that will do, there would be also progressive damage to the cells in the brain. Can you switch off, please? Because I get distracted. Sorry. So there is a brain damage too. The cells are disappearing. But that's called senile changes happening, dementia happening. And they can't control the temperature, so no wonder these patients get hypothermic when you put them to sleep. And there is also change patterns, so they can sleep on, off, any time of the day. People over 65 years of age, about 1/3 of them will have some degree of loss, memory loss. And 1/3 of those population will suffer depression. So that is the scale of problem we have. On top of the aging changes happening, in dementia, two things are happening. One is called plaque. The plaque is inside the cell. And the another one is called tangles, which are inside the cell. And these things are causing damage to the brain. In terms of the other system, I won't go into the detail. The lungs are losing tissue, kidneys losing tissue, the liver is losing tissue, and heart is becoming stiffer. So now you can see our problem. If you anesthetize these patients, you will deal with all those kind of problems. And one of the worst thing is the patient who is losing memory. Normal people get a bit of arthritis with the age. And if they don't mobilize after the operation, no matter what operation, there is more problems. So the recovery takes longer. And if you got a patient with a dementia, that's going to cause even more problem. So what happens about the drugs? Everything would be affected. The drugs don't get absorbed that quickly. The distribution changes. The metabolism is slow. It can't come out of the system. Sorry, I'm trying to make it very simple for non-medic people, so I'm not going into the detail. So every system is affected. So there was another one. Okay. When they look at how do you, when you're anesthetizing them, what do you need to consider? Actually, the dose requirement is much lower in elderly with the dementia. So it's a 30 to 50% less adult dose for propofol. Volatile agent, you need 30% less than adult. You don't need opioid that much because that is going to be very potent and last longer. The effect won't be that over. The muscle relaxant take longer. It will be there, so you need to monitor your neuromuscular function. Diabetes is very common. And as the diabetes is common, you got other problems with the heart, the brain, the kidney, you call it, they get the problem. So you do have increased diabetes and diabetes-related morbidities. So now we have got the assessment issue too. And there are problems. You can't get the history from these patients, so you got to do a lot more tests. But important thing is to assess their memory. Where are they? In cognition. And the other thing is frailty. Okay. There are hundreds of tests for dementia. And I could not find a system how to assess this patient. We are not neurologists. We are not physicians. We are anesthetists. But fortunately, I found a system, a tool, which was published in 1980s, called Global Deterioration Scale, GDS. What it is, and this is one of the most important slides of my whole talk. The dementia has got the stages. Number 1 stage, no dementia at all. Normal person, normal aging. And you go further down, and then here, the patient is not with you. Doesn't know anything at all. But in the middle, that grades. So I have put number 5, stage 5, and just let's look at what happens. So stage 1, no cognitive decline, normal, healthy person. Stage 5 is major memory deficiency and needs some or more assistance for routine tasks. Now you can imagine brushing teeth, eating, having a cup of tea, going to the toilet, not cooking. These things happen. And if you go beyond that, we'll come back to that later a bit, that these patients, you have to think differently. But between 1 to 5, not that bad. So why all patients going for cataract labeled as dementia, general anesthesia? The one other talk I wanted to introduce to you is something called frailty. And you hear people talking about, oh, he's very frail, she's very frail. What it means, the physiologically, the person has deteriorated much compared to normal population. And when the patients are frail, they do get a lot more complications. That's known. So the suggestions are that if you do have a patient who is very old or older, or particularly dementia, you should look at the frailty score. And that will give you some idea, so you can tell your patient that your relative is not going to do that well. The next problem is consent. Obviously, these people are incapable of doing that. And every country has got its own, mental act. So Indian Mental Act, I think there is an Indian Mental Act, 2017. Singapore has got 2005. UK has got 2005. Singapore Mental Capacity Act is 2010. So every country has got its own. Let's look at the effect of anesthetic. Why I'm talking to you? Why are we saying that let's look for another option than general anesthesia? Because these patients do have increased morbidity, mortality. They don't do very well. And these questions are being asked in public. Newspapers are flashing, saying, why are you administering general anesthesia to these patients? Let's look at that. This is a newspaper saying general anesthesia is bad for dementia. Not only that, the scientific community is also questioning, should we give general anesthesia to the patient with the dementia? So let's look at something else. What we know from the study is something called CAMCOG score, Cambridge Cognition Score. So 100 means no memory problem at all. And 80, if you go below 80, then it's start to make dementia. Okay, let's look at what happened. If the person is around 100 score, whether you do surgery or don't do surgery, they are no different. Okay, and I would come in there. But the moment they are near the red line, that means they have developed dementia. Look at what happened. This is no surgery. So remember my definition I gave you of diagnosis? Dementia is progressive, loss of cognition. So even if you don't do any surgery, there would be a decline in the memory. But if you did do the surgery, look at the decline, much faster. So telling you that general anesthesia may be bad for you. The next problem we have is that when you anesthetize somebody, when they wake up, they don't know where they are. This is called emergence delirium. That's how we will describe. So that will happen within hours or day. Later on, when the person is still delirious, and there is no reason, that is called post-operative delirium. Post-operative delirium. In short, it is called POD. And if the cognition continues to decline, then that will come under post-operative cognitive dysfunction. But consider, you got a patient with a dementia already. Memory loss has already happened. How are you going to assess whether the patient got POD or whether the patient got POCD? So it's a very difficult assessing these patients. And surely these patients are not going to do well. Do we have evidence from the literature? There is some evidence coming in human and animal model. The anesthetic could be bad for you. But when you go into more detail, they say, there is no significant association. But these were older studies, and the evidence was not strong. But the newer evidence coming in, they are saying, may be associated. So you can see the difference. Some are saying may unlikely or not significant, but they are not saying that it is not associated. But those who are saying may be associated, there must be something in there that the anesthesia is causing the problem. And there is also saying propofol may be better than sevoflurane. So try not to use the gas if you got to give general anesthesia. Let's look at delirium. What is a delirium? It's an acute condition and it's a fluctuating alteration of mental state. That is, they are reduced awareness, they are disturbed attention. And 36 to 50% of people, those who have got cognitive decline, the incidence of POD, post-operative delirium, is very high. And it starts from 5th day to 3 months. Now, what about anesthesia? This is one of the very biggest study. 404 papers on POD, post-operative delirium. What they said is common after general anesthetic. It has associated with the adverse events such as poor quality of life, increased morbidity, mortality, and length of stay. And they suggested avoid GA, avoid sedation in these patients. Okay. But when you look at the other newer, what they're saying, patient with preoperative cognitive deficiency suffer more POD, but unlikely to precipitate dementia. So that's good. It's in favor that it doesn't cause any problem. But when you look at the other studies, they're saying, yes, patients who suffer POD are more likely to be diagnosed with subsequent cognitive dysfunction or dementia. So if the person did not have dementia, is likely to get one. And they are saying if the patient is already cognitively impaired, they are high risk of developing POD. So it's all appeared to me a bad news for us. Let's look at the last problem, that is a post-operative cognitive dysfunction. This is a syndrome again, defined by a drop in the cognitive function. That's a memory again. But it's a very definite different thing, POCD, post-operative cognitive dysfunction. It has to have a diagnosis before you did anything. And those tests must be repeated after the operation. If you haven't done the test and you haven't repeated that, you cannot qualify to call it a post-operative cognitive dysfunction. But it happens. We know that it happens. And the incidence is about 26% in non-cardiac and pretty high, 80% after cardiac. So we know it happens. And you have heard the phrase, either grandfather went to the operation and he's not the same. Grandmother had the operation and the grandmother is not the same. So what has changed? Something has happened to their brain. That's why they are not that good. And they say that the POCD happens more in advancing age than people, those who have got cognitive dysfunction. So the question is, does POCD worsen dementia? You got a problem, no clear link, and some are saying there is a link. So we are not sure what is happening. And I mentioned about this paper, based on some of the published, we got the congratulatory email in 2016. They came out and they said, POD, POCD is very common after surgery. There are long-term consequences. Give information to the parents, carers, or relative. You must tell them that what's going to happen. But when you look at these data, there is a problem. Why I'm saying that to you? One study is saying no problem, the other saying there is a problem. The problem is inherently in the science. They are case-controlled study, they are case series, they are audits, they are quality improvement program, and virtually there is no randomized controlled trial. And if you don't have a randomized controlled trial, how can you come out with the evidence? You can't. Cannot grade the evidence. So the results are inconsistent. But certainly there are problems with the GA and POD and POCD. And all these studies, even including us, when we published the editorial, we said further research desirable, which is true. If something is not giving you the answer, you do need to do more research. But one thing is a problem, which I mentioned earlier. All these studies are non-ophthalmic. There is hardly anything in the eye. There is nothing. To our knowledge, the editorial we wrote in 2016, we gave some insight. What's the problem there for the eye cases? So the scientists around the world, they are saying, hey, we are not getting the answer. Let's meet. And they met. And they came out with a consensus. And it's important for people, those who want to do the research. They came out that there are problems with the definition. There are problems with the methodology. Let's do something else. They divided now 3 things. They said, if the person has got memory loss, call it a neurocognitive disorder. If the person develops cognitive decline after the operation within 30 days, call them postoperative delirium. They left the term there, POD. But they said POCD should be replaced by postoperative neurocognitive disorder. That means any decline happening between 1 month to 12 months, we call it a postoperative neurocognitive disorder. And what they did with the consensus, they sat and the same paper was published in 6 major journals. I've never been aware of that. How can you publish the same article, same authors in all these 6 journals? But what they did cleverly, they contacted all the editor-in-chief of all these journals and they said, we want to get this message around. Let's do more research. Dementia is increasing, population is increasing. Let's do some work. Okay, because they said, general anesthesia is bad for patients with a dementia. Is regional anesthesia any good? Yes, looks very good. That you can avoid the problem of the general anesthesia. You can avoid opiate. My friend Frederick will agree that you should avoid opiate. Analgesia is not a problem for cataract, but it can help to some extent. POD and POCD, we don't think it's a problem with the cataract anesthesia, regional anesthesia. So I put a question mark there. And of course, if these patients can go home quickly, they can move about quickly, those are the advantages. But is it hunky-dory for everything? Not really, because these patients are not communicated to you. They are uncooperative, many of them. Many of them are agitated. There is a chance of conversion to general anesthetic, which we had to do 1 or 2 cases. We set out with the regional, but we had to convert on the table. And we have talked about sedation all day today. Jagdish talked about it. The sedation is very common in eye surgery. And if you use sedation in dementia, you're looking for more trouble. Okay? So there are adverse events of sedation. You need time to do the titration. And the patient has got cognitive dysfunction. How are you going to assess it? Patients are covered under the drape. Who was presenting 4 or 5 cases of patients who had a brain stem anesthesia. You don't know what's happening to these patients when the whole body is covered, not talking to you. And we know that there are respiratory depression can happen, sudden waking up, sudden movement. And I can tell you from our experience, if you do sedation to these patients of dementia, the matter gets worse. So please try not to do sedation to these patients. We have written about it. The paper had just not come out yet. It will come out in a month's time in Anesthesia Journal on the problem of the sedation. And some of my colleagues, Tom Eek, Prof. Edwin Sheet, Mike Irwin from Hong Kong, Girish Joshi from America, we have all got together and we thought we got to sort this problem out. So what we have done in Singapore, what is our experience? Okay, as I said to you, doing a randomized controlled trial is not feasible in these patients. Very, very difficult to do. That's why nobody had done it. So what did we do? We looked at this scale of GDS. And remember scale 5, it shows that here the patient is losing memory a bit, may still be eating his own, may still be taking bath, but doesn't know where he lives or she lives. So that was our marker, that if anybody was less than 5, and we did this quality improvement project, and remember Prof. Edwin Seat also talked about choosing wisely. That's a concept going around the world, and it will come to you. Everybody would be talking about choosing wisely initiative. So we applied this choosing wisely initiative. We set our marker on 5. Anybody less than 5, we'll give them RA, whatever the way they have been listed. And if it is more than 5, we know the patient is irritable, patient doesn't understand you at all, not communicative, so you are looking for trouble. So there you have got nothing to lose, because these patients have already lost. The only problem would be, by giving general anesthesia, can we make it worse? Perhaps I don't know the answer. So what we managed to do, we reduced the GA rate from 48 to 36. Not a huge, but even 10%, happy to do that. And our regional anesthesia rate from original listing from 44 to 64. So we have made some improvement. So what's my take-home message for you? Patients with dementia is living longer, and you are going to get them more and more in your clinical practice. Important point I said, that all patients of dementia are not exactly the same. There are stages of dementia, there are spectrum of dementia. Of course, general anesthesia is the easiest option. You want to do it, because you got nothing to lose. But its effects are controversial, but we definitely know there is an increased morbidity and possibility, I'm not saying definitely, possibility of worsening of dementia. RA, regional anesthesia, is feasible in selected cases. I'm not saying you list everybody dementia under RA. Try doing it. And there are gaps, we need more research. And I thank you very much for your kind attention and in the late evening.
Thanks a lot, sir, for that informative talk on a sensitive and empathetic topic. With this, we come to the end of the inaugural ceremony. A heartfelt thank you to all the dignitaries, our international, national and host faculty. We are extremely grateful for our international and national faculty who have come all the way on their own. Thank you, dear delegates, for attending this conference. We thank each one of you who have contributed in making this conference a big success. Now we request you to stay back for the entertainment program, a musical night by Miss Shri Priya. You have had a glimpse of her music, followed by cocktails and dinner. We'll assemble here tomorrow for another insightful and interesting session. Thank you all.